Thank you very much, Mr. Nika. So good evening, everyone. My name is Zina Saeed, plastic surgery registrar working for Mr. Nika at the Royal Free Hospital in London. So tonight's paper is Intramedullary Screw Fixation for Metacarpal Shaft Fractures. It's a biomechanical human cadaver study published this year in the Journal of Hand Surgery, the European volume by Lebert et al. So we all know that metacarpal fractures are prone to functional deficit when they're inadequately treated. So the current management for unstable metacarpal fractures include the use of either open reduction and internal fixation with plates or K-wires, and we've seen some of these in the polls. So now an additional method of inserting an intramedullary cannulated screw over a guide wire is available and has caused a division amongst the hand surgery community. So the aim of this paper was to compare intramedullary headless compression screws with dorsal compression plates to evaluate their biomechanical performance in stabilizing metacarpal shaft fractures. So in terms of the methods, two sets of experiments were performed. In the first, the biomechanical characteristics of the screws were analyzed in an artificial bone model. So as you can see in images A and B, two Delrin tubes were connected with either a 2mm 4-hole compression plate versus a 2.2mm cannulated compression screw or a 3mm cannulated compression screw, and each group consisted of 6 samples. Then next, the intramedullary screw and dorsal plate fixation were compared in the human cadaver model, and these are shown in images C and D. So 6 fresh frozen cadaveric hands were dissected and the metacarpal bones were harvested. Transverse osteotomy mid-shaft fractures were created, and the bones were randomly assigned to either dorsal plating or the retrograde intramedullary screw fixation group. There were 12 in this group, so 12 in the compression and 12 in the so 12 in the plates and 12 in the screws. 11, you had 3mm compression screws used, and only 1 had a 2.2mm cannulated screw. Next, in terms of mechanical testing, the cantilever bending test was performed to assess stability and fatigue resistance of the constructs. And then a micro CT 3D imaging was performed, and you can see these images as well. And this was used to calculate the ratio between the intramedullary diameter and the screw diameter in the bone specimens treated with the cannulated compression screws. So now in terms of the results, so first of all, the artificial bone model results. And as you can see from these diagrams, the purple arrow is for the plate and the orange for the screws. So in the artificial bone model, cantilever bending testing revealed a statistically significant lower load at failure for the 2 intramedullary screws versus plating. And you can see this with the orange arrows. Cycles to failure and bending moments at failure were also significantly lower in the compression plate group compared with both the screws. The screws were lower than the plates. In terms of the results for the human cadaver model, load at failure, cycles to failure, and the bending moment were at failure significantly lower in the compression screw group versus the plates. Now, in terms of our critical appraisal, so we felt this study had clear aims and objectives. It was a powered study, and a priori study was used to achieve 80% power. They did use a previously established bone model and cadaveric model to more closely mimic in vivo effects. They did indicate that randomization was used for the cadaveric model. They did have a very thorough and detailed methodology in terms of preparation, testing, and they did use objective measurements. So the measurements were found on the machine integrated software. They did account for both axial and cyclical loading, and we did feel there were clinically relevant and valid outcomes. They did account for all samples, and the results importantly did support that of previous studies, and they said that there were no conflicts of interest. In terms of the possible confounding factors, there wasn't a clearly defined hypotheses, and they did very much use the minimal sample size required. And again, just in terms of selection bias, there wasn't really any detail in terms of the randomization, and there were no blinding either. Again, in terms of the external validity, this was in question, but the authors very much did talk about this in their discussion, that the samples may not be a true representation of the patients that we see in our hand trauma centres, as they were older patients with degenerative bone processes. And again, they did mention the variation in bone quality and size. And of course, as this is a biomechanical study, we don't have the stability from adjacent soft tissues. They were controlled osteotomies that were performed. So again, may not represent fracture patterns that we would see clinically. And of course, the authors did also say that not all other fixation methods were considered. And I do need to point out that there was support from MedArtis in this study as well. So in summary, we do feel that this was a valuable addition to the literature. It provides biomechanical data which predict success of cannulated compression screws prior to the use in patients. The most important question is, would it change my clinical practice? From this paper alone, probably not, but it does provide important information that can guide clinical practice. And of course, as always, further studies are required to support these results, and ideally, of course, a randomized controlled trial, but that, of course, is not without difficulty. Thank you very much.
Brilliant. Thank you, Nina. So I think now we'll proceed to asking each panelist their experience with cannulated screw fixation, and some of the panelists have got some short presentations. So we'll start with Thomas Giesen, and if Thomas, you can share your screen. Thank you.
So good evening. Thank you again for the invitation. I'm Thomas Giesen. I was used to work in the University Hospital of Zurich, where I think kind of this adventure started for us. And I'm very happy to be invited tonight to talk about this. And I'm happy that who came after me at the University Hospital of Zurich is keeping on with the legacy, basically, of the intramedullary fixation of the finger fractures. Before starting, I now work in Tessin as a south part of Switzerland in the Clinic Ars Medica, and also at the university, it's not university yet, Hospital of Lucerne. There are no conflict of interest to disclose. So metacarpal and phalangeal fractures is an extremely broad subject, and basically tonight we are talking, and I was asked to present basically tips and tricks about the technique about fixing metacarpal and possibly also phalanxes. Basically, we use for metacarpal the intramedullary screw fixation for a specific pattern of fractures, and basically transverse fracture of the shaft or distal shaft, and also for the slightly oblique fractures. We don't use intramedullary screws for very proximal fractures or for oblique fractures. About comminuted fractures, we could open a discussion that could last for hours, basically. We use it sometimes, the screw as an internal fixator, but not adding compression, just holding the length. In some cases, we think the screw fixation could be a golden indication. For example, when we have multiple metacarpal fracture, closed injury, also open injury, and we use them also in replantation. Because of course, if someone has 2 or 3 metacarpal broken, to put a plate on every single metacarpal could be quite demanding for the patient about the scarring and the material and the surgical access. Regarding the boxer fracture or the metacarpal neck fracture, me and my associates were still kind of doing 50-50 using the classic intramedullary K-wire or the screw fixation. For the other fraction like this one, we are definitely now using the intramedullary screw fixation. We don't use the plates anymore. We can discuss later the reason, but basically the reason is the technique is very fast, easy. There's no exposure of the fracture. There's basically no scar. And the fixation, as demonstrated by this paper we are discussing tonight, is stable enough to allow early mobilization. We use these kind of screws, but we don't have anything against other screws. Just at that time we had these screws, and when we published our paper, we published the paper using these screws. The technique is quite, put it like this, easy. There's some tips and tricks to be careful about. A guide wire is inserted from distal to proximal by bending the proximal phalanx and just inserting the K-wire till the fracture. At this point, if the fracture is somehow dislocated, the K-wire, the guide wire, is used as a joystick just to reduce the fracture, and then is advanced. We took care to advance the tip of the K-wire just in the base, in the cortical bone at the base of the metacarpal, in case you're going to drill. Now, the screws we are using from Medartis, they are self-tapping and self-drilling. So actually, most of the time, we are not drilling the bone, but sometimes I will show you later, we are doing this. So if you think you're going to drill, it's better just to fix the tip of the K-wire at the base of the metacarpal, so by drilling it's not coming out. And at this point, we just insert the screw. This is the fracture we saw before, and just one example. As you can see, at 3 months, the functional result is quite good. And then we can discuss and show in just cases. There's a canonic, a kind of, how do you say, usual case. Some cases might be make us reflect or think about a couple of things. The first one is a young patient with a negligible dislocation. This patient could have healed with a cast, with no operation. But sometimes the patient wants, we actually offer the patient the possibility to put the screw. We say, okay, there's a risk of an operation, but if you want, we can put the screw. The difference is there's basically no immobilization. You can move straight forward, not using the hand, that's different, but you can move straight forward. We fix this patient with the screw. And as you can see, and this is one of the critical points about using the screws we can discuss also later. Basically, sometimes there's not much compression on the fracture side. And so the bone is healing on secondary intention, like making a callus. Is more an elastic fixation, like putting a K-wire, more than putting a screw, just putting some compression and actually stabilizing everything. Is this a problem to us? Not really much. And this comes also in the discussion, which screws are better, long thread, short thread, bigger size, smaller size. I think the only discriminant for us is the length of the screws. And actually right now, several brands are making longer screws. Sometimes we go fracture that are a little bit more complicated than the usual boxer fracture. Intra-articular displaced, young patient, more fragments. In this case, we variate the technique by inserting the K-wire not from dorsal but from palmar. And it looks a little bit savage to put it from palmar, but the alternative, my question is, what would it be the alternative to this? By inserting this screw from palmar, we actually we did more or less the same incision you do for the trigger finger. And actually from palmar, we got the fragment and we inserted the screws. And as you can see, in this case, it's not exactly intramedullary screw. There's a variation of the technique, but basically the screw is holding on the cortex. In this case, we drilled because we look later. Or this is another case. This is another special case, put it like this. is a young patient, again, very young. His old fracture is already healed, and he has pain as a click in the joint when he's bending. So in this case also we actually had to open in order to reduce the fracture and give a proper shape, and then we fix with the screws. With the screw. Of course, the problem here is that we probably had a very good, at least to us, result radiographically. But the moment we opened the joint, of course, the patient took more than 3 months to regain an optimal range of motion, because the moment you open the joint, then the finger tends to become stiff. Our tips are to drill or not to drill. We were talking before. We do drill if it's holding on the cortical bone, because the tip of the screw is not strong enough to make a hole in the cortex, especially in the metacarpal. The cortex of the metacarpal is very strong. Right now is coming out a wrist prosthesis that's actually hanging on a metacarpal diaphysis, so it's strong. And the other thing is very important before drilling or choosing the size of the screw. It's important to measure the isthmus of the canal on the true lateral view. This is the narrowest view, and that's what you need to know, how much is diameter of the isthmus. If the diameter, and nowadays with the digital X-ray is quite easy, you ask for we always ask for 3 views, AP, oblique, and lateral. On the lateral view, the isthmus should be always measured. And if it's, for example, 3 millimeters or bigger, then we go for the bigger screw. If it's smaller, we go for the 2.2 screws of this Medartis set. And now new sizes are coming up. If the intramedullary canal is just right or slightly smaller, then we drill, because otherwise we can risk to break the screws when we are inserting the screws. It is one of the main problems. If you break the screws, the head of the screws or the wall screw when you are inserting it, then this technique from easy technique and very easy becomes a real nightmare. I would say I'm witnessing this, as it happens to me twice, once in a metacarpal and once in a phalanx. There's no fun at all if the screw go broken. The other tips I got is a kind of strange tips, but it's very important. When you are inserting the screw actually sometimes it becomes hard and it starts to squeak. It makes a definitely sound as a squeak. So any squeak, it's a really warning sign. Stop pushing the screw, or first slow down a lot. And if it's keeping on squeaking, remove the screw, re-drill, or consider changing the screws on a smaller size. And the third thing is kind of crazy to say, but it happens to me once. And sometimes by inserting the K-wire, it bends a little bit. It just bounces on the cortical wall and then it bounces back. It bends a little bit. I don't change the K-wire, accept this, because the screw has a little bit of elasticity. So the screws might bend just a little bit and then become straight again when it's inserted. The main critics about this technique are about articular damage. That's every meeting I went, basically, it was the main critic. And I go also kind of assaulted once about this. About the metacarpal, I'm kind of okay with it, because the insertion point is not on the loading, I would say, on the area of the articular surface that is holding the load of the finger. And we just don't say us this, it just demonstrated already in 2013. So basically the insertion point, if you use the dorsal, of course, technique, is not in the load bearing area. The other thing is about the damage. Actually, we did this in Graz. We went to Graz in the anatomical lab to demonstrate how much damage you do on the head of the metacarpal. And you actually, with the biggest screw, and you damage 8% of the cartilage. And we use a 2-dimension model. It means this is overestimated. Actually, the damage is even less. The second common critic is a compression. And do we have a real compression? My question is, and now we can discuss eventually later, do we need compression in hand? the hand is so well vascularized, I think, and I learned, because I learned like this, that in hand fracture, the main problem is not the non-union, but is the malunion and the stiffness of the finger. So I just wanted, like a provocation, just put in a case like this. This is a case I did 7 years ago. I was in the UK, and don't tell you why I did this. It was a technical problem, so I had to do this. This a fracture probably is for a screw or for a plate, most likely, or just immobilization. I didn't have anything. I used just a long K-wire. I don't do this routinely, but in this case, I had to do this. And this is the healing. It's not perfect, but the patient was moving very well. And actually, as you can see, there's no rotational stability, there's no compression. So the last
We rush you now, Thomas, sorry, just because of time. We need to rush you, sorry.
Yeah, well, it finishes the last slide. Okay, the second common critic, the last common critic is about rotational stability. And to us, the answer is metacarpals are not femurs. The metacarpal is never alone. There are other brothers, the other metacarpals with ligaments and muscles and everything. So we think that actually the metacarpal has the tendency to re-rotate and realienate automatically in a right position. And that's why the syndactyly is good enough for rotation. And the second thing is a personal observation that basically all the corrective osteotomy I've done on metacarpals were after plate fixation, because with the plate, actually, the metacarpal cannot re-rotate.
Thank you.
And
thank you so much, Thomas. That was very insightful lecture. We are going to carry on with Carlos. He's going to give us his thoughts on the paper and also the technique. I'll let you share your screen, Carlos.
Well, thank you, Thomas. That was very, very elegantly presented. Nice technique. There are a couple of questions we need to answer. I think one is, what is the standard treatment for these kind of fractures? And from the question to the audience at the beginning, it becomes clear that we don't know. And then it comes to a matter of personal preference. But if, let me see if I can advance that. That advancing or not? Yeah. So if it's a practically undisplaced fracture, yes, you could fix it, but you don't need to. And if you use a body strapping or syndactyly bandage, as it rotates, that will correct your rotation. As you flex the finger, you will not allow it to rotate. So just bend them gently, and some of them could be treated like that. This is the kind of fracture we're talking about, transverse in the shaft. And can you treat this conservatively? Well, yes, you can. It's a bit more hard work. You cannot put a lot of padding. So what we do is we tend to put some tape, and then you're going to try to get a 3-point fixation. So pressing on the dorsal metacarpal in the middle and underneath the metacarpal, proximal and distal to that. So you're going to end up with a cast where you see the impressions there. And that was this type of cast was popularized by Nicholas Barton, and that works very well for many fractures, and they'll heal within 3 weeks. So you don't need that for very long. So that's one good option for these ones. The other one is the intramedullary fixation, which you've shown some examples where you have displaced fractures, particularly if it's more than one metacarpal. And one to quite like is this, the Easy Dry. That grabs the K-wire very well and allows you to rotate it and manipulate it. So you're putting that just by hand from the proximal end. You bend the K-wire like a ski and make yourself a hole at the proximal end of the metacarpal and just take care of the dorsal branch of the ulnar nerve there. Then make a hole with a drill bigger than the K-wire you're going to put, and then just get the K-wire and just pass it in. Check always the rotation clinically. Don't trust the X's for the rotation, and just get them going. So you go from this to this. And one thing following Thomas' comments is that the shaft of the fourth metacarpal is usually the narrowest. Fifth metacarpal has a nice medullary cavity. It's easy to get the screw. The fourth can be very difficult. And that hits very well. And you can cut the wires flush and leave them in if you want, or you can leave them a bit longer and take them out. There are of course complications, infection, displacement, wire removal, that can happen. And then the other line of management reflected in the question at the beginning is that you can play these fractures. For example, this was a professional football player. He wanted to go back playing soon. So you discuss the options. He wanted plated, and you play them, you get them moving immediately. That was him at 3 weeks. So the two questions that I'll put to the panel is, what are the indications for this? And what is the evidence to support this? Now, I agree with Thomas that some cases you have to use the cannulated screws. Like there was a completely crushed hand with severe soft tissue injury, and the only way to fix the third metacarpal was put 2 little cannulated screws. That's fine, but that's the exception to it. And we are changing practice without providing clinical evidence for it. And if we don't do it now, we'll carry on doing this and we'll never know what the answer to these fractures is. And that's all I wanted to say for now.
Thank you, Carlos. That's a very insightful talk as well. I think we'll move on to Jamil. Jamil, can you make any comments on Carlos's talk?
I agree that we have to be cautious whenever we have a new technique. We have to be cautious. We have to collect evidence. I absolutely agree with you. I think at the moment it's a novel, relatively novel. I mean, it's only been the last few years, and just like Thomas said, I second everything Thomas said. It was very eloquently put, and I agree with almost. Has he gone? Has he gone? I agree with everything he said. Oh, there you are. Sorry. There are longer screws. We need longer screws, and we need smaller screws. And the mechanics of it change when we use the 1.7s. They're really quite flexible. So we just have to understand that the principles of what we're doing are not the same as people might think intuitively, in that we're not necessarily going for rigid fixation. Metacarpals always heal. I mean, they always heal. I've taken to theatre as a registrar with a consultant one case that was supposedly non-union, and it was actually united at the time. So metacarpals will heal. So we don't need to have the same. We don't need these screws. We can use other techniques or nothing. You know, sometimes nothing is the right thing to do, especially in people who keep punching things and getting fracture upon fracture. So I'm all for, and I'll join in any major big study to provide the research for it. But I'm a huge advocate, and I'll show you some cases. So if I share my screen. Sorry. So I haven't got many slides. I'm just saying the same thing that I've just said there. At the moment, since I've been collecting data, I've got about 60 screws, about 30 metacarpals, 5 proximal phalanges, 5 middle phalanges. I've had 2 complications, and they were early on. One was an arthrodesis, not trauma. It was a thumb IPJ, and I didn't think. I thought this is a great technique. I've used it for DIPJs, and there was no grip on the proximal, on the thread, on the long thread of the screw, and it was just, there was no purchase, and it just wobbled around. So she failed in arthrodesis. I've had 1 screw break, which Thomas mentioned about the squeaking. I'll talk about that again in a video. That's really important. I didn't know that was like my 3rd or 4th screw that I was putting in. And Medartis said, I use Medartis screws, but again, like Thomas, I have nothing against any other screws. just what we've got on the set on the shelf. And I was putting a screw in, and they told me you didn't need to drill, so I was using it without drilling, and the screw head broke off. It was squeaking, but it actually broke when I was trying to remove it, because once it's so embedded and wedged inside there, the material is very thin, and the torque is incredible. And as I was trying to unscrew it, it didn't strip the thread like other screws do. The head just sheared off. And then I had to over drill the metacarpal head. That was a nightmare. And I was doing it under local anesthetic, because I do all these cases under local. And the guy was fine. He was fine. But I took it out. I had to over drill, and I had to use a Operace kit to remove the screw. Took a long time. Took 2 hours in the end. But I put another screw in, and he was fine afterwards. He's lost the follow-up. He's not answering his phone, and I can't get any pictures or anything of him afterwards. But that was my complication. Apart from those two, I've had no infections, no screw removals, and no evidence yet of any arthrosis, but it's still early. So quickly going through, I'm going to have lots of pictures in this. This is the last actual slide.
I think you'll only be able to share two cases.
Yeah, I've only got 2 cases. Well, I've got lots of cases, but 2 cases I'll show. A 24-year-old man who was on holiday, caught his hand in a car door, got crushed, and he delayed his presentation and came to us 10 days later. So can you see my screen? Can you see so this is his fracture. Can you see that? Yeah. So typically, there's quite a lot of angulation there. This is him on table, local anesthetic. You can see the adrenaline there, and his position is just got a depressed knuckle. I did offer him, you can treat this conservatively, and I said to him, you don't have to have an operation here. So the advantages are you don't get that bump on the back of your hand, and you can get moving straight away.
Brendan, we're going to do the last check. If you can just...
So this is a video of me doing the whole operation in compressed form. It's only mildly compressed, actually. The whole procedure takes about 10 minutes. So I make a little nick in the skin. Once I've reduced it, make sure that it's in the right place. I'm feeling around where the metacarpal is, and that's my nick in the skin. Although you'll see later, I do make it a little bit bigger. Take a K-wire, guide K-wire. It just goes over the top. You see how I'm holding the metacarpal, getting my position right. You've got to aim correctly, and I've been doing this quite a bit now. So you've got to make sure that you're aiming towards the base of the metacarpal. People often aim in the wrong direction. Sometimes you can, the entry points, you want to be slightly radial or slightly ulnar, because then you can position the head on the shaft. Sometimes that's quite useful to use as a technique. So once I've done that, I made my hole a little bit bigger, and what I do here is I countersink. So this is basically dilating the extensor tendon. I don't actually make a hole in it. I don't incise it. I used to. I don't do that anymore. I just push down. Once I've got into the head, you'll see that I push it hard. Once I've got through to the cartilage, then I put a bit more force, and then I just wriggle it back, because I don't want to lose the cartilage bits that are on the countersink. They stay on the head there, and you can't see it there, but there's a little bit of cartilage still on the head. So I don't want that to stay in the joints. Then I use the measure just to push down, and I really push that down to make sure that I'll show you the x-rays of this, and then I measure. I've taken x-rays, I'll show you those afterwards. I wanted to include those in the video, but so when I do put my screw in, I make sure that I'm tensioning the skin, so I have a little contact in the skin as possible, and I just drive straight through the tendon. And I didn't at first. I used to make a cut, but then I thought I'm making the hole bigger. When I've looked in these afterwards and I've seen the hole through the tendon, it's tiny. It really doesn't do very much. These are super sharp screws, and they just go straight through. Several different things in the technique here I think it's important to stress. You must not push. The screw thread does all the work. So, and there's different bits that you feel. So first you feel the thread go through the head, then you feel it loosen up, and then you get to the fracture. And you see I'm reducing the fracture there, making sure he's awake, so I ask him to make a fist. And then I make sure, and then once the head engages in the cartilage, that's when you get your compression. You see now it's starting to get a bit stiff. So I'm making sure everything is firm, and once I've got through and my fracture is reduced, I don't have to worry about holding that so much. And then you'll hear some squeaking. Did you hear that squeaking? It's really important that you don't overdo it at that point. You have to feel how much that squeaking is. I know now how much squeaking is okay and how much is not, because of that one screw that broke.
Can you straighten your fingers for me?
And then on table,
All the way
you
straight
see
as
the
you can.
intrinsics are blocked because of the adrenaline, so I just push them down and he's got no extension lag.
And then turn your hand over the other way. Make a fist, all the way down. And straighten it again. Make a fist.
And so on table, that's what he's doing.
And last time, make a fist. And straighten.
So for him,
Relax again.
you know, this is at the end. That's the one absorbable incision. I use either that
Make a fist.
or,
and then straighten again.
I mean, his little thing's coming all the way down on table. Now, I know he's got local anesthetic in.
Straighten again.
So,
is there any pain there at all? Any pain during the procedure?
So he says again, no pain during the procedure there. I don't know if you could hear that well.
I'm mindful of time.
I know, I just need to show these few things. I'll be quick.
Okay, no worries.
So first of all, check my position on those views. You have to make sure your length is right to try and get as much grip in the cortex as possible. That's the dilator and the screw going in and checking the position there. And then this is him at a week. And then this is him at 2 weeks. Full range at 2 weeks. And that's his scar. You can see that little area there. It's his scar. And again, he says,
straighten your hand fully. Then make a fist again. That comes all the way in. Is there any pain now?
No.
Is there any pain during the operation?
Not during the operation, but then once the anesthetic wore off a bit, I could feel it. Like, it wasn't bad, but then within the next day, I was back at my desk working full-time on a computer, using my hand.
So you were back at work the next day?
Yeah, back at work the next day.
Straighten again.
okay, and I mean, that tells a story that I don't think, you know, you can argue, well, you can argue with it, but it's quite an impressive story. The other case I've got, you probably don't want to see, but I've used a derotation osteotomy. Let me just, I won't show the videos, but I'll just quickly show. So this girl, a 40-year-old woman who was walking a dog and the dog pulled, and I put a cerclage wire technique here, and I thought it was all okay, but she had a slight rotation, and you can see here, this is her before the operation, when I did the derotation. That was her finger scissoring. And at the time, I think when I did the first operation, I think she was a local anesthetic, but I can't remember. So this, I did a derotation osteotomy by making an osteotomy there, put my wire in, put the screw over the top, close the gap, and then that's the gap closed, and then she's derotating. And this is her a week later with a full range of movement.
Thank you very much, Jamil.
Okay.
We're going to move on to, thank you very much, Jamil, for your talk. It was beautiful, beautiful videos and illustrations. We'll move on to Dr. Frew. He's actually the senior author of the paper that we initially discussed, and I think he will just comment on the paper and his experience, and I'll get him to share his screen. Thank you.
Thanks, Dr. Nika. Can you hear me? So basically, I'm co-senior author. Of course, Maurizio Calcani is the true senior. And thanks for the invitation. And I also want to acknowledge Thomas for bringing this technique to Zurich. He basically brought this here, and we are still working with it and have a lot of fun, and also a few complications, which I want to show you. So can you see my screen? Can you see the screen?
Yes, the screen is fine, Florian.
I'm sorry, do you hear me now?
Yeah, we hear you.
All right, so I'm going to start again. Maybe you didn't hear me before, sorry. So I'm going back. So I'm working in Zurich, and First of all, I want to acknowledge Thomas for bringing the technique to Zurich, and we are still having a lot of fun and also a few complications, as you will see in a minute. And we have heard that the screws are one main advantage is that you can leave it inside, but what do you do when it makes problem? And this guy, he obviously has a lot of fun hitting other people in the face, and 1 year after the first surgery, he refractured the bone and obviously also bent the screw. So how do you remove it? And it's not that easy because you cannot use the retrograde technique, how you brought it in. So the only way you have is basically cut the screw, remove the proximal part, remove the distal part, and this can be very ugly. As you can see here, we also have to remove a part of the dorsal cortex of the bone and then basically drill out the whole screw. So this is really a true nightmare, as you can see here. But in the end, of course, with a distal radius graft on the plate, it can end nicely. And I also want to share one nice fracture with you before we go on. We have already seen Thomas, and I think Dr. Carlos has shown that these fractures can also be treated using the intramedullary fractures. How would you basically fix it? I'm very curious to hear on your opinion. So are you going to use wires, intramedullary wires, intramedullary screw, plate even to buttress it? So we also used a open reduction and internal fixation using headless screws. And you can see here very nicely that it's, in my opinion, one of the only options to basically restore metacarpal length, which is pretty difficult in this kind of fractures. Yeah, it's basically already all. Thank you very much for the invitation and a very, very nice journal club. Thanks.
Thank you very much. It's interesting. I did a fracture last week, very similar to what you've just shown there, and it was very useful, the cannulated screws that for that indication. Thank you. I'll just move on to Mark Pickford. He wanted to share 2 cases. I don't know, Mark, can you share your screen yet, or?
I emailed them to you, Doris.
Oh, emailed them. Okay, let me just get them up. Did you email it to my NHS email?
I can't remember. Do you want me to check?
Yeah, I haven't got it on my Hotmail. Let me just bring it up. I haven't got it on my email yet. Sorry, Mark.
Hotmail. Send it to your Hotmail account.
Yeah, send it to.
I've already sent it there.
It could be in my junk mail.
Yeah, it might be.
Darius, can I make a couple of technical comments while you find the presentation? Just a few technical comments for people. One of them is that you use the K-wire as a joystick to reduce it. That tends to bend the K-wire a little bit. Yeah. If you rim it on power, the rimmer can break the K-wire, and then you end up with half a K-wire in, half a K-wire out. And you can ask me later how I know that. So don't do that. Yeah. Then the next thing for these head fractures, something that you may be interested in is that there are now very small cannulated screws. In several companies have that 1.6 millimeter screws, and I think they're going to be very useful for this.
I did one on Friday, exactly the same, with an intra-articular head with a step with 2 1.7 screws. I've got some nice pictures. It is such a beautiful screw.
It is a nice thing. And the other thing, people say use whatever screws you want. I agree with that. Just take notice of one thing. In some systems, the screwdriver shaft is thicker than the screw. And in some systems, the distal inch of the screwdriver is thinner. Yeah. If you try to sink it in with a screwdriver that's bigger than the screw, you may split the head. So just watch that little detail. Have a look at the screwdriver in relation to the size of the screw. Yep. Thanks for that.
Thank you. Doris?
Mark, I don't have it, but I've got pictures of the case right now on my computer of the case that when I was hand fellow with you, the broken screw. So do you want me to share that?
Yeah, please do. So actually, this is a case that Doris and I did together. It was a woman in her 50s in a low-speed rollover RTA. and she presented with a crush injury. This happened in Spain, and they temporized in this way that you can see here. And actually, they did a great job because she devascularized the middle and the ring fingers, and they were free from perfusion unless they were held in a perfect position. So for 24 hours, those K wires they put in did a really good job. They're thick K wires, 1.6, and with a lot of work to do, I put a 3mm compression screw down the shaft of the index finger proximal phalanx, and it worked a treat and was in moments. And as I started to put this screw into the middle finger proximal phalanx, you can see it broke off, as we've heard about as a complication from Thomas and others. So I'm really interested to hear you all talk about the impending sound of doom, the dreaded squeak. But I think that there are a couple of kind of points I'd add to this. So since I've heard that squeak, I want all the trainees I work with when I'm putting these in to listen for it. So I listen to music all the time in theatre, but when I'm putting these screws in, the music goes off. I think it's really important that you don't try and whack these screws in really fast, because when you look at the internal, the cross-sectional sort of structure of the screw, and you can see it in the index finger here, there's a big space inside that shaft for the K-wire. So the amount of metal in the shaft for the screw is not that great. So they are not that strong. And I think it's really important that you choose the right size of screw. And Thomas talked about measuring on the X-ray. I just actually take an X-ray with the screw held next to the bone I'm going to fix, and I guesstimate whether I think it's going to be right. I try not to put it in too quickly, and I listen carefully for that squeak. And if it starts squeaking, I start to go back one, forward one, back one, forward one, or take it out and use the other strategies that you've heard of. So here it snapped off with about 1 centimeter proud of the head of the proximal phalanx. So bear in mind, we were going back down the hole that the Spanish surgeons had already poked a 1.6 millimeter K-wire down. And each time I grabbed that shaft and tried to twist it, it just snapped off and off and off until we had nothing we could hold on to. And at that point, rather than drill a great big trough down the distal shaft to retrieve it, I took a diamond burr and I burred it until it was completely flush, in fact, slightly countersunk in the head. Now, the disaster here is actually not in the short term, but in the long term. And although I'll never be certain whether I caused the problem, her joint was completely destroyed. By a year down the line, that PIP joint had gone from being a healthy looking joint on plain X-ray to having considerable destruction. It looked like it had an inflammatory arthropathy. So that's one disaster. And, we can all show great cases where these have worked brilliantly, like the index finger here, but actually, I think it's more helpful to talk about these disasters. So I think the size and the way you stick it in really matters. And we got away there with 1990 wires. The other case that you can't see, but I can describe to you very well, is we all also abreact to the complications we've had in the past. So I had a fusion to do this summer in a DIP joint of a patient who put a circular saw across his middle finger DIP joint. And having had this screw snap off, I was very keen not to have that experience again. So I put a 2.2 millimeter screw across the joint, and it was beautifully reduced on table. And when I x-rayed him a week later, there was a 5 millimeter gap between the bone fragments because the soft tissue spring had just pushed the bone over the screw and distracted the joint. So you can go too small as well. Too big can be a problem because of the screw snapping, but if you go too small, you can create a problem. Maybe not such a big problem, but it did mean he had to have another operation in which I was able to easily extract the screw and replace it with a 3 millimeter, and he's gone on to successful union. The other just little technical point I would make, and this is something that I know Doris has touched on in his book on tips and tricks, is that I personally do as much planning as I can before I stick the K wires in, and that is by using blue needles and other needles to make sure I get my planning right, so that I do as few passes with the K wire as possible. I try and get it right the first time.
Thank you so much, Mark. So I'll just move on to Matt Gardner. He hasn't got anything to presentation, but he's got some comments on different screws and just some technical pointers.
Thanks very much, Doris. I was just going to make a few comments. So I think the paper suggests that probably these screws meet the minimal sort of biomechanical requirements for fixation. But I think the main thing is we talked a bit about lack of evidence, and a review that Justin Wormold led called Forte looked at extra articular fractures of the fifth metacarpal, and there were only 2 RCTs, and they were for K-wires. So I think there really is a dearth of evidence in this area. The other sort of mantra, I suppose, is no innovation without evaluation. And I think we're all, potentially innovating. Certainly my colleagues, particularly Richard Baker at Wexham, is really pushing the intramedullary screw fixation. And I've done some as well. And they are great fun to do, and we've had some brilliant results. But actually, it's all very well being fantastic on table, but would there be a difference at 3 months, say, between the screw fixation and the conservative management, for instance? And I think the longer term follow-up needs to be done in comparative studies. And I think Jeremy will touch on this a bit more in a second, which will be interesting. I do wonder whether we should all be contributing to a registry. Perhaps the BSH registry might be a good spot. And again, Jeremy, I'm sure will comment on that, because I think some prospective data collection, at least initially, would be helpful. And then finally, just in terms of the actual screws, at Wexham we use the Accutrack screws. They're fully threaded, and I think they deliver very high torque on insertion, and they do maintain the compression. But I know there's some papers looking at whether the minimally threaded screws are actually better. They give you a lower torque, but then the downside is you may not get that compression, although the compression may not be needed. So I wonder whether people might comment on the different types of screw they use. Finally, I think Arthrex have got some biocompatible screws. And I think Jill asked a question about, having to remove them perhaps down the line. And I wonder whether anyone had used biocompatible screws, because they might be an option in terms of longer term, reducing longer term problems or overcoming issues around having to remove the screw, particularly if they fracture.
They're probably very expensive, aren't they, the biocompatible ones?
I don't know, actually. I'd be interested to know, yeah.
I'll just introduce the last speaker. Thank you so much, Matt. Jeremy, he's just going to make some comments on the paper and all the different discussions that we've had. Thank you, Jeremy.
Yeah, no, thanks, Darius. Yeah, I mean, I am somebody on this panel who has never used this technique, and frankly, I've never seen this technique. And I must admit, this paper I really thought was actually really nicely worded. I really enjoyed reading it. I thought it was measured, balanced, sensible. Nina's provided a critique and highlighted the strong points, but I'd really commend the authors, because I don't think they've gone into any overreaching clinical conclusions that this kind of very much experimental work could be reached out to perhaps by some other authors. So I really think very well done with that. So with that paper, I mean, where does that leave us, and where do we move forward? Well, I wanted to have a look for some of the clinical evidence that Carlos has touched on, Jamil's touched on, and Matt's touched on. And there was a systematic review that I know Darius will know, because he wrote a letter about, which was in PRS in 2019, and it showed that there was a case report of this in 2010, and then there have been 8 retrospective cohort studies in the literature when they did this review in 2019. So how do we actually pull that together in terms of clinical practice? Well, I don't know. I mean, maybe everybody here is familiar with the ideal framework, and I'm going to, if I could share my screen, if somebody could enable me to share the screen, I was going to put a slide up about that and just talk about it for just a minute, because at the minute it's got disabled attendee screen sharing. There we go. So, so Matt said that the words "no innovation without evaluation," and that's the title of this paper, which in 2009 in the Lancet, which talks about IDEAL, which is an acronym for how we could take surgical procedures from an idea into safe clinical practice. So rather than the Wild West of just having a go at something, we actually take it through a stepwise process. And this has actually been updated in 2019 for anybody interested. There's a new version in the Annals of Surgery in 2019. So if we take the 2010 case report as number 1, the idea, and maybe if we're being generous, the 8 retrospective case series as 2A, I mean, I think we're a bit generous. I think this paper fits a bit in there. It's about technical and procedural success and how things fit together, so that's reasonable. What about 2B, 3 and 4, which is where we start to get into prospective, ethically approved comparative studies? And there don't seem to be any of those at all, complete dearth. So that's where we really need to go. And that, that's what Matt's alluded to. And in the absence of that, and seeing as it's quite late in the evening, I was going to spice it up a little bit and wake people up and say, in the absence of that, anybody who's using this in routine clinical practice, are you conducting experimental surgery on your patients without ethical approval? And does anybody want to comment on that? It's perhaps a bit spicy, but it's late in the evening, why not? Let's get to some fisticuffs on it. Is this experimental surgery that should only be done in ethically approved registered studies and databases? Anybody got
Jeremy, the problem is a lot of the stuff that we do in hand surgery and plastic surgery, it's a level 3 or 4 evidence. So, you would say that a lot of the stuff that we do is, it would be experimental. So I kind of disagree with you there. I'd say,
a lot of older stuff. Yeah, I mean, pre-2009, there was no ideal. Fair enough. Plating's been around since, I don't know, whatever, the ancient Romans or ancient Greeks or whatever it is, something like that. So fair enough. You can back that to it. But if you were to go up in court with somebody with broken intramedullary screws, and I stood up opposite you and said, well, the ideal framework says that basically this is experimental surgery, there's no comparative evidence that this should be done at all. How would you answer that? I mean, I don't, maybe I'm wrong. I mean, I'm just a year 1 consultant. So
may I shortly answer? Experimental surgery, when you try a new idea that was never done before, as far as I know, by definition of someone. Now, if I can shortly share my screen, I can I want just to show you 2 slides is about history of this technique. And actually, the history of this technique is quite long, because the first cases published with 300 plus cases were done in the 80s. So we're actually not inventing anything new. If I can, I'm sorry, presenting again some slide, but basically the study is it's basically like this. This technique, you can find the first time in the book that most of us study on it, was la main traumatique, the traumatic hand. It was translated in many languages. But the referral to this technique was actually a paper early published by Professor Fouché in the middle of the 80s with 300 plus patients. And this means that what was missing at that time was the technology to insert the screw, because all these fractures were open fractures. So there was no technology to do this. But actually, the story about intramedullary fixation of the fractures, it goes back years and years. If you're talking about the tibial fracture, we are going back to the Second World War, or the first one. So basically, Kirchner is a beginning of the century. So intramedullary fixation is definitely not experimental surgery. Using a screw into a long bone is a kind of intramedullary fixation, and devices like the one on the left were already published in the 80s. What we did, we applied an old concept with a new technology. And actually, as I put it down, Del Pinal published the first, is actually the one who reintroduced the idea, and he realized there was the technology to put the screws in the phalanxes, and we just followed it, and because it made sense. So I don't think we did any experimental surgery. And we came also from a long history of literature. The metacarpal fracture, there's some paper already in 2013 with 50 plus patients. So that's what I'm saying, basically.
Does anyone else want to make any comments? Thank you, Thomas. Thank you, Jeremy.
Yes, could I make a comment?
Yeah.
So I think actually the NIHR is funding a study led by Roa Taha in Nottingham and Lexia Karantana on extra-articular metacarpal shaft fractures. The FACT study, they're doing a feasibility study, I think with a view to perhaps trying to organise a randomised controlled trial of surgery versus no surgery. So I think I would encourage everyone to look that up and contribute. I think Jeremy was certainly spicing things up. I think probably it's not experimental surgery, as Thomas was alluding to. I think probably putting metalwork in that way into a bone is within a reasonable spectrum. But we do owe it to patients to try and build the best evidence possible. And I think, given that there's now lots of people doing it, as Jeremy was alluding to, we really should be contributing to higher quality evidence and the generation of that. We won't be able to decide tonight, but I think there is potential for something bigger.
Can I just make a comment on that as well? I think, I've gone through a learning curve. We've had some complications, and I think most people who start any technique for the first time will have some complications. And maybe that's because we don't fully understand what we're doing at the beginning. Maybe we haven't thought of everything that we ultimately know we have to think about. I mean, we haven't even touched on all the little nuances. Thomas was the best at describing how many factors to think about. But even then, we haven't talked about so many things that I try and consider and I try and teach my juniors. So to suggest that this is a technique that it is simple, but it's simple when you know what to consider. And if you don't consider all the things, then of course you might make mistakes. Of course you might have complications, and you're going to have a greater difficulty. So I'm very wary of suggesting that this is something that everybody should do just because they've seen it described. That's not how you should do it. I agree. So evidence is we need that.
I hear you.
Can we ask the panel members, are there situations where the advocates of the technique, where they would not use it?
Lots. If you don't need an operation, don't do an operation. I don't do it for everybody. And, conservative first, the advantages you've seen in my video there is that if somebody needs to get back to movement, I mean, people can go to work the next day. That's quite impressive, really. You can't, if you're in a cast, if you treat something conservative, you're in a cast, you can't necessarily do anything. It will heal, but you can't necessarily use your hand in the same way. I think that either do nothing or be reasonably aggressive with minimal access, because then you do as little soft tissue damage as possible. I think those are my principles. So there are lots of cases that I wouldn't do. And people come to me thinking that I'm aggressive as a surgeon and I put a lot of metalwork in. I actually would rather treat most things conservatively.
Does anyone else have any? Mark, you were going to make a comment?
The fracture configurations that Thomas put up at the beginning, I think, are a starting point in what we should do and what you shouldn't do. And, I think we probably accept slightly less ideal fractures as we get more and more confident with the technique. I would just urge a little bit of caution about the early mobilization. So we had a case in East Grinstead where we fixed 2 metacarpals, mid-shaft fractures, in a 16-year-old lad, and put him in a soft bandage and sent him away. And he came back 3 weeks later with 2 snapped screws. So I think, you need to choose your patients carefully who you go for that early mobilization. And I think we were probably a little bit overconfident asking a 16-year-old who'd fractured his hand by punching a wall to behave himself afterwards. But I think, coming back to Jeremy's point, and I think it's a good point, a valid point, I don't think it's wildly different to a lot of the techniques that are currently there. Thomas, once again, quite rightly pointed out that if there's a problem after fracture management, it's almost never about non-union. It might be about malunion. It's almost always stiffness. And Jamil has just quite rightly pointed out too, that the less soft tissue damage you cause, the less you contribute to that post-operative stiffness. So I think that's another good principle. So I think it is a sound technique, and I'm happy with it. But I absolutely agree, and this is philosophy, isn't it? But I absolutely agree that just because something comes out of a shiny packet with a CE mark on it, and it's got a fancy advert and the hand gel, don't assume it's a good device to use, because we've seen disastrous implants come and go. So you have to use common sense as well.
Thank you. Anyone else want to make any comments?
Can I make a comment, Dariush?
Yes.
From my experience of doing secondary surgery after metacarpal fractures that have done badly, it's interesting that most of them are the ones that have been operated on by somebody. It's rare that I have to go into metacarpal later on that was treated conservatively. So if you compare the two groups, the best results will be in the fixation group, but the worst results will also be on the fixation group, and the other ones that go wrong. So the stakes are much higher once you decides to fix this, and you're going to have a few disasters, and you're going to have some spectacular successes, which is nice, but we have not quantified that. And we're giving the impression here that we are evolving care, and we have not provided the evidence to, one, put patients through these, and two, spend public money on a technique that I cannot back up when somebody comes and calls me. And to physicians, this is unbelievable, because to them, this is a very clear outcome, is a very clear diagnosis, is an easy to do study from their point of view, and we haven't done it. And even then, we think we can change practice. Now, our justification is, well, we do that all the time, so that's fine. You know, but we're gonna be picked on this sooner or later, and we better have the evidence by then.
We've got a good question here from Jill Smith. She asked, should we be considering prevention and referring patients for anger management instead of operating on them, as there are many recurrent offenders?
Is Jill talking about the patients or the surgeons?
Oh, I wrongly perhaps assumed she was talking about the patients.
All right.
Especially in Derby.
But an angry
Jill.
bunch. Yeah.
Thomas. Can you unmute yourself, Thomas?
I'm trying. I saw in the chat before, there was someone asking of the audience about what about removing the screws? I don't know what its experience. I heard the two possibility, and I want just to add one. So the easiest case is when the screw is not broken and you want to remove it, even by the patient wants the screws out. I have one tip about this, that the screw, once the head is out, the head of the screw is outside the bone, the screw is not gripping anymore. So you can turn your screwdriver as much as you want, but it won't come out. So you need to see the head of the screw and pull actually with some instrument. I normally use a curved bipolar. I go underneath the screw and I pull it because there's no grip. And this is the most benign situation. Then there are two situations. One is the screw is broken and is stuck in the intramedullary canal in the isthmus. If the fracture is fixed, one solution could be with the diamond burr to flash the screw. This happened to me once, as it was said by Mark before. And but this is a real disaster. It's a real disaster, but we don't know how much damage we did to the joint. And of course, cleaning all the metal dust might be a nightmare, and we don't know what are the consequences later. And the other situation, which you have actually to do a longitudinal osteotomy on the bone, a wedge osteotomy on the bone, might be okay on the 5th metacarpal. Good luck with the 4th metacarpal, as happened to me, because as Carlos pointed out, the 4th metacarpal is the narrowest one, and actually to do a longitudinal osteotomy without breaking anything down is quite challenging. Also, Florian showed one case like this. So that's why this technique is fantastic and easy if the things are done right. If anything is going wrong, namely breaking the screw or getting the screw stuck in the medullary canal, it comes from stars to mud, real mud.
Thank you. Could I ask Mark Pickford, what did you do with your 16-year-old boy with the 2 broken screws?
Put him in a splint.
Can I ask one more question?
Yep.
I would love to share my screen once more and maybe also particularly ask Thomas, can you see the screen?
Not yet.
Not yet, sorry, now?
Yep.
So this young guy almost lost his hand under a vehicle, and you can see there were open fractures all over the hand. and I fixed 3 of them with the intramedullary screws to spare the soft tissue. And of course, there were no non-unions, not surprisingly. However, all these joints here, where I went through with the screw, made a very ugly contracture, like almost 60 degrees. And any ideas about how to prevent this contracture? Because I clearly do somehow associate it with the transarticular approach, Thomas.
I think you may be being a bit hard on yourself there. I think when you've been in a rollover RTA, there's probably a lot more damage there than simply the fractures that you see. And it could be that no matter what method of fixation you use, you'd have had a similar outcome.
Yeah, I agree. However, I have the impression I have a lot of IP flexion contracture when I use the transarticular approach in the fingers.
I don't have that same experience. I've got some other pictures and videos which I can't show now. But you've seen how I do it. I literally just make a little nick in the skin, and that's it. And then I go through like that with the finger flexed. So I make sure that I'm right in the middle, between in the sulcus between the condyles. I'm slightly dorsal, and I don't do any dissection. I literally just put the screw over. In the proximal phalanx, it's quite different because the canal is much bigger. In the middle phalanx, it's a very narrow canal. So when you're doing through the DIP and flexing here, often I have to drill. So that is not the same thing. And proximal phalanx is, I haven't had any problems. I don't know whether, do you do any dissection or do you just put the...
Not at all, just like you guys
Right.
did.
I mean, I've only had 5 cases, so I've not had a lot.
If I can comment, so basically, first, if that's quite a difference between Del Pinal way to put the screws in the phalanxes and our way. Because when we started, we knew he was putting the screws in the phalanx, but we had no idea which kind of approach was he doing, because it was kind of a gossip we had from Spain, from one of the fellow. So basically, when you put the screws in the retrograde manner, on the X-ray, you always see the footprint of the screw. And this might be, this one comment, might be a little bit disturbing to the patient and to your best enemy, this is your best colleague too. So anyone who wants to critique you will say, oh yes, you see this on the X-ray. Of this is relevant, I cannot tell you, because as Del Pinal pointed out, it's actually on the dorsal side, so it's not load-bearing area. The second comment on your case is, I do suspect possibly whatever you've done with this fracture in this hand, you got palmar plate contracture even in a sprain. So in such an injury, I don't think is the screw to blame about the contraction.
Can I make a quick comment? For the proximal phalanges, we often go antegrade actually and try to avoid the PIPJ, and that seems to work quite nicely. I think the less interference with the PIPJ in any scenario, the better. And actually the MCPJ seems to be a bit more forgiving in terms of access. And again, you can take a very minimally invasive approach and it works nicely.
You saw that video that I showed that went through the PIPJ and she had a full movement of her PIP. Now, I agree with you. PIPs are really very sensitive to any trauma or anything like that. I agree with you also. Proximal phalanx, I didn't show any pictures, but accessing proximally to distally is often better. So if the fracture is closer to the base, then going proximal to distal is better. The thickness of the cortex is a lot more distal in the proximal phalanx. So if you've got a distal neck fracture, then I would go distal to proximal because you get enough grip in the thread in the central part of the canal where it's still thick cortex. But if you're anywhere proximal to the mid shaft, I would go proximal to distal for that reason that you've said.
We've got a question from Samir Gujal. How does the complication rate for headless compression screws compare to K-wire plate? I'll ask that to Jeremy. I mean, I don't think there are any papers. Are there any papers? Nobody?
No, there is one paper.
Nobody knows.
No, there is one paper. We actually cited it. Is from, if you give me 2 minutes, I find it out. But the complication of finger fracture with plate, K-wire, and screws intended as external cortical screws is pretty high, up to 26%, if I have right in mind. If you give me 2 minutes, I'll come back with the paper.
Be interested to see. Yeah, thanks.
Thank you. Is there any other questions?
I'll just make a quick comment while Thomas finds the paper. When I started fixing fractures and plating them in the hand, I had a percentage. I had to go back and take the plate out and do tenolysis, and I felt quite bad actually. You know, my rate of reoperation was quite high. And then I saw my boss, Frank Bird, talking to somebody. He was going to plate some phalanxes and said, you realize you're signing in for 2 operations, one to put the plate in and one to put it out and then tenolyze it. You're very lucky. You may not need the other one, you know, but that's part of the procedure, you know. So after that, I didn't consider the complication anymore, and my results are much better, you know.
That's great.
I think we do need to think about rounding things up shortly. I'm just interested to know whether people have been influenced at all by COVID, because access to theatre has been much more difficult. So in my practice, certainly if there's an option of conservative management, that is definitely what I would suggest, both for reasons of minimising complications and also just actual logistics of getting patients into theatre. Anybody got any comments on that?
Yeah, I've been a bit more conservative recently. And we've been using a lot of wide awake surgery and blocks. We used to use much more general anesthetic for our hand trauma patients. So that's changed. It's disrupted our practice quite a bit. Anyone else noticed any differences?
Just one more comment. I think everybody's done that. We all try to be very conservative. And what will be interesting is, are we going to have a wave of malunions coming up when we come out of this? My prediction is probably not.
So what we like to do to end is just ask the question again about practice. Having heard all the comments from tonight's discussions, how would you manage that fracture? Darius, can you put that picture up again just to remind the audience? So we'd like to just do another poll. How would you manage this fracture? MUA and splint, K-wire, plate, tension band, or cannulated screw? Have the audience changed their minds?
It's getting tense, this one.
Somebody's moved to a tension band. Okay, well, thank you very much, everyone. It's been a fantastic discussion. If anybody has got another topic they would like to discuss at Phronesis, please do get in touch. We've really enjoyed tonight. Really appreciate the time of all the panel members. Many thanks indeed, and good night.
Thank you. Thank you, everyone. Good night.